Immune checkpoint inhibitor is a type of drug that blocks protein called checkpoints, such as PD-1, PD-L1, and CTLA-4, produced by immune cells, including T cells, thereby enabling immune cells to kill cancer cells more effectively. Recent advances in the development of immune checkpoint inhibitors have substantially improved the prognosis of a variety of cancers, giving rise to a new era in oncology. However, the increased use of immune checkpoint inhibitors have also raised concerns for increased number of reports with autoimmune toxicities, including neurological toxicity. To investigate the characteristics and risk factors of neurologic adverse events related to immune checkpoint inhibitor use, we conducted an observational, retrospective, and pharmacovigilance study using data from the FAERS database. FAERS, or FAERS, stands for FDA Adverse Event Reporting System, and its database consists of spontaneous adverse event reports submitted to FDA by healthcare professionals, consumers, and manufacturers. Among approximately 4 million reports submitted between 2014 and 2019, we identified 50,406 reports of immune checkpoint inhibitor-related adverse events, of which 3,619 reports, or 7.2%, were neurologic adverse events. We found that the use of immune checkpoint inhibitors was associated with increased risk of multiple neurological disorders, including hypophysitis, myasthenia gravis, myositis, vasculitis, Guillain-Barré syndrome, meningitis, and encephalitis. On the other hand, immune checkpoint inhibitor use was not associated with neuropathy or demyelinating disorders. However, the different analysis using information component, which is a value used to find new drug adverse event signals, implicated that immune checkpoint inhibitor use may be potentially associated with neuropathy later in the study period, or in 2019. We also found that older age and dual immune checkpoint blockage were a risk factor for fatal neurologic adverse events, while female or male sex was not associated with increased mortality. We also looked at the interval between the initiation of immune checkpoint inhibitor use and the report of the adverse events. The interval for overall neurological adverse events was 1.58 months, which is about 48 days. Some adverse events such as myasthenia gravis and myositis occur earlier, while other adverse events such as hypophysitis and Guillain-Barré syndrome occur later. So in summary, we found that immune checkpoint inhibitor, either alone or in combination, was associated with a higher risk of various neurological adverse events than other drugs in the FAERS database. Older age and dual immune checkpoint inhibitors therapy were related to higher risk of mortality from neurological adverse events. And the interval between onset of adverse events and administration of immune checkpoint inhibitors is variable, while most of the adverse events occur in the first few months.